Ladies and gentlemen, please rise to welcome the ceremonial procession. It is my honor to now invite Dr. Bimsara Senanayake, our orator, Dr. Senanayake, President, Ceylon College of Physicians, and the Joint Secretaries of the Ceylon College of Physicians, Dr. Chiranti Liyanage and Dr. Chanaka Abe Ratna, to join the head table. You may be seated. I now cordially invite Dr. Senanayake, President, Ceylon College of Physicians, to introduce our orator.
Dr. Bimsara Senanayake, MBBS, MD, FRCP, FCCP, is a consultant neurologist at the Institute of Neurology, National Hospital, Sri Lanka. Dr. Senanayake obtained his board certification as a neurologist from the Postgraduate Institute of Medicine, University of Colombo, in the year 2000, having completed MD Medicine in 1997 and MRCP UK in 2000. He is a fellow of the Royal College of Physicians of London and the Ceylon College of Physicians. He has been a member of the Specialty Board in Neurology at the PJM continuously for over 12 years and currently is chairperson, and a member of the postgraduate curriculum development committees in neurology, neurophysiology, and neurorehabilitation at the PJM. He was also appointed as an honorary senior lecturer at the Department of Clinical Medicine, University of Colombo in 2016. He is also a life member of the Sri Lanka Medical Association. He is Sri Lanka's national representative and national delegate for the World Federation of Neurology and the national representative for the Multiple Sclerosis International Federation, which produces World Multiple Sclerosis Atlas. He is an international advisory committee member of the Asian and Oceania Congress of Neurology, and a committee member and an invited chairperson of Pan-Asia Committee for Treatment and Research in Multiple Sclerosis. He is a medical advisor to the patient support group Multiple Sclerosis Association of Sri Lanka. Dr. Senanayake played a pioneering role in the creation of Association of Sri Lankan Neurologists in 2006 and the primary professional body for all practicing neurologists in Sri Lanka. He went on to become its founder joint secretary and later president in 2012. He is the founder president of the Movement Disorders Society of Sri Lanka, which is an affiliated member of the Society of International Parkinson and Movement Disorder Society, which has over 11,000 members. He represents Sri Lanka in the review subcommittee of the Asia-Oceania section of the Movement Disorder Society. He is also the founder president of Sri Lanka Committee on Treatment and Research in Multiple Sclerosis and Related Disorders, formed in 2018, which also collaborates with European Charcot Foundation, a leading MS research group in Europe, and has continuously held 5 annual SLC TRIMS ECF symposia since 2019 with the participation of world-renowned experts in the field. Dr. Senanayake is also a member of the American Academy of Neurology and is a director of the World Parkinson Program. He is actively involved in both undergraduate and postgraduate teaching in neurology for the last several years, and is also an examiner in both undergraduate and postgraduate exams. He has trained many young Sri Lankan neurologists over the years. In 2012, Dr. Senanayake launched the first dedicated neurology journal in Sri Lanka, Sri Lanka Journal of Neurology. He also had a brief stint as a consultant neurologist in UK NHS. Dr. Senanayake has published widely in many reputed international journals and has over 125 publications. He is the principal lead investigator in many multi-center international clinical trials. He has been an invited speaker in many national and international meetings. Ladies and gentlemen, Dr. Bimsara Senanayake, the orator of Cyril Fernando Oration 2024.
First of all, good morning, distinguished guests, ladies and gentlemen. It's my singular honor and privilege to be invited by the Ceylon College of Physicians to deliver this year's prestigious Dr. Cyril Fernando Memorial Oration, which was first delivered 53 years ago in 1971 by Professor Bruce Perry. I'm also incredibly grateful to the President and the Council of the College for giving me the opportunity to present some of the pioneering work done by us in the field of multiple sclerosis and related disorders in Sri Lanka over the last 2.5 decades with international collaboration. This work created greater awareness, diagnostic capabilities, and treatment options, uplifting the lives of many hundreds of affected patients with these previously lesser known neurological disorders. Dr. Cyril Francis Fernando, OMG, OBE, MD, MRCP, was a Sri Lankan clinician and researcher. He had completed his primary education at St. Benedict's College, Colombo, and he attended the University College London, qualifying in MBBS in 1925, later obtaining the MRCP in 1926 and the MD in 1929 with gold medal honors for the best performance. In 1949, he was appointed officer of the Order of the British Empire, OBE, and 1955, he was made a companion of the Order of St. Michael and St. George, OMG. Dr. Fernando was a great clinician and in every sense of the word, a great doctor, a good doctor. He was appointed physician to the outpatients at Colombo General Hospital and was an external faculty member and examiner at the Ceylon Medical College, Faculty of Medicine, University of Ceylon. He was an active member of the Ceylon Medical Association, a branch of the British Medical Association, BMA, now the SLMA. He was successively CMA's honorary secretary, treasurer, vice president, and president in 1948. Today, the CCP commemorates his memory with an award of a gold medal oration. The evolving landscape of multiple sclerosis and related disorders in Sri Lanka, a 25-year exploration. To get a general perspective, let us first listen to the life-changing stories of two young girls who presented to us and consented to come on camera to share their experiences. They both face serious challenges in their young lives, afflicted with these diseases early on in life, and successfully overcame them to lead normal, productive lives.
මම දෙවන වසර මුදුකාංග ඉංජිනේරු ශිෂ්‍යාවක්. 2017 වසරේදී A-level විභාගයට පෙනී සිටින විට මගේ ඇස්වල පෙනීමේ දුර්වලතාවයක් සහ අත්වල දුර්වලතාවයක් ඇති වුණා. එවිට හමු වූ වෛද්‍යවරයා විභාගාතීතය නිසා එම රෝග ලක්ෂණ ඇතිවිය හැකි මට කිව්වා. නමුත් රෝග ලක්ෂණ තවත් උස්සන්න වූ නිසා වෙනත් වෛද්‍යවරයෙකු හමු වී MRI පරීක්ෂණ කළා. ඒක බලලා මම දවස් කිහිපෙකින් අත් කකුල් පණ නැති වී ජීවිතක්ෂයට පත්වෙන බව කිව්වා. එයින් සෑහෙන කම්පාවට පත් වූ නිසා මම කොළඹ ජාතික රෝහලේ ස්නායු වෛද්‍ය ඒකකයට ආවා. එහි වෛද්‍යවරු පරීක්ෂණ දෙස බලලා මට මල්ටිපල් ස්ක්ලෙරෝසිස් රෝගය වැළඳී ඇති බවත් එය බෙහෙත් කර පාලනය කළ හැකි බවත් පැහැදිලි කළා. දැන් මම අවුරුදු 7ක් බෙහෙත් දිගටම ගන්නවා. දැන් මට ගොඩාක් හොඳයි. මට මගේ ජීවිතය සහ සීන යලිත් ලැබුණා.
So that was a story of a young girl who presented to us 7 years ago. During her A-level examination, first symptoms developed and subsequently diagnosed with multiple sclerosis, and now currently treated and followed up by us, and she's a software engineer leading a normal life. And this is a story about a young medical student, final year.
මම අවසන් වසර වෛද්‍ය ශිෂ්‍යාවක්. මට දැන් වයස අවුරුදු 28යි. 2021 අගෝස්තු මාසයේදී මට ඩබල් විෂන් කියන රෝග ලක්ෂණය ආවා. ඒ කාලේදී මට ඔන්ලයින් ටීචින් තිබුණ නිසා මම හිතුවේ ස්ක්‍රීන් ටයිම් වැඩි වුණ නිසා රෝග ලක්ෂණය ආවා කියලා. නමුත් මම ડોක්ටර් කෙනෙක් channel කරාට පස්සේ ડોක්ටර් කිව්වෙත් මේක ඉබේම හොඳ වෙයි කියලා. ඒ වගේම සතියක් වගේ කාලයකදී රෝග ලක්ෂණය සම්පූර්ණයෙන්ම නැති වුණා. නැවත 2022 පෙබරවාරි මාසයේදී මට රෝග ලක්ෂණ ආවා. හැබැයි කලින්ට වඩා වැඩි කාලයක් තිබුණ නිසාත් මම ඒ කාලේදී ඔප්තල්මොලොජි අපොයින්ට්මන්ට් එක කරමින් හිටපු හින්දා මම මගේ කන්සල්ටන්ට් මැඩම් එක කතා කරාට පස්සේ මැඩම් මාව අයි හොස්පිටල් එකට රිෆර් කරා. මෙතනදී කරපු පරීක්ෂණ වලින් පස්සේ යාලා තීරණය කරා මේක ස්නායු සම්බන්ධ ගැටලුවක් හින්දා මාව ජාතික රෝහලේ ස්නායු වෛද්‍ය ඒකකයට යොමු කරන්න. MRI සහ අනෙකුත් පරීක්ෂණවලදී යාලා තීරණය කරා මට තියෙන්නේ relapsing and remitting type multiple sclerosis කියන රෝගී තත්ත්වය කියලා. ට්‍රීට්මන්ට් පටන් ගත්තට පස්සේ මට අද වෙනකන් කිසිම රෝග ලක්ෂණයක් ආවේ නැහැ. මගේ අධ්‍යාපන කටයුතු බාධාවකින් තොරව සාමාන්‍ය පරිදි කරගෙන යන්න මට හැකියාව ලැබුණා.
So multiple sclerosis was first described in 1868 by Jean-Martin Charcot, the father of modern neurology, as a new neurological disease. Charcot's handwritten manuscript and the original color drawings of a center of a plaque illustrates the expansion of the lesions from the ventricles to the cerebral hemisphere. Before Charcot, Sir Robert Caswell, a Scottish pathologist, described and illustrated many clinical details of MS, but he did not recognize this as a separate disease. John Cuvillier, a French pathologist, described the pathological, give a detailed pathological account as credited by Charcot himself of the condition. MS is the most common immune-mediated disease affecting the central nervous system, with 2.8 million people affected globally. Myelin is produced by oligodendrocytes, and in MS, myelin is attacked by the immune system, leading to demyelination. As a result, demyelinating plaques occur in the brain, spinal cord, and the optic nerves. MS affects young adults, mostly females, between the ages of 20 to 40, but it can occur at any age. Globally, the average age is around 32. In Sri Lanka, we find it to be around 29. It affects people differently. Some have very mild symptoms with mild, little disability, whereas the others can have worsening symptoms with greater disability over time. MS presents in episodes known as relapses, which are short-lasting clinical events depending on the site of lesions, which resolve fully or partially. Episodes sometimes are followed by long stretches without noticeable symptoms. The disability can be due to these relapses, which are relapse-associated worsening or raw, or it can be totally independent of the relapses as well. The MRI has revolutionized the diagnosis and the surveillance of patients with MS. Not only we can diagnose and confirm the diagnosis, we can also follow them up and the treatment responses with MRI. This scan shows the dissemination of these brain lesions in time and space over a period of a year, and the new lesions occurring in different parts of the brain, which is disseminated both in time and space. So the different MRI sequences help us to diagnose it clearly. For example, the T2 flare lesions with corresponding black holes in T1 images. These lesions not only occur in the brain, they also occur in the spinal cord and the optic nerves. The MS, the pathological hallmark of MS is the white matter lesion. The white matter lesion is formed within the CNS. They are a result of demyelination and axonal loss caused by migration of inflammatory cells into the CNS via the blood-brain barrier. Global prevalence of MS has been worked out by the MS International Federation, which comes out with the Atlas of MS every few years, and the last edition was in 2020, after the previous edition in 2013. And it shows that number of people living with MS around the world has increased globally over the last few years. Now it is said that about 2.9 million people around the world live with this condition at a prevalence of 35.9 per 100,000, an increase from 2013 when it was 2.3 million. Every 5 minutes, someone somewhere in the world is diagnosed with MS, and at least 1 in 3,000 live with the disease, and in some high prevalence countries, it can be as high as 1 in 300. It occurs in children as well, with over 30,000 children affected all over the world. And it has this striking geographic variation, which is very characteristic, perhaps due to the global latitude gradient, distance to the equator, genetic and environmental factors may contribute. So globally, MS prevalence is rising in all regions, including Asia. So in Sri Lanka, we find that MS prevalence is around 7.8 per 100,000 population, crude prevalence. So in the 1990s, when we started as trainees in neurology, MS was more or less uncharted territory. Existence of MS in Sri Lanka was even questioned at the time. Lack of awareness, knowledge, availability of diagnostic tools, disease-modifying treatment, limited neurological services resulted in poor mobility outcomes and visual outcomes in these young people. MS was not taught as a subject in medical schools. We had only a couple of low-resolution MRI scanners for the country, entire country. So health policy makers were unaware of this condition existing in Sri Lanka, and insurance companies did not list it as a critical illness. Worldwide also, around that time, we didn't have the McDonald criteria, so we had to rely on the POSA criteria, which was less sensitive. MR imaging was primitive, less sensitive again. We didn't have the serology, the biomarkers for aquaporin 4 and MOG, so there were a lot of overlap, and diagnosis was not precise, so diagnostic errors were there. And there were only 2 disease-modifying drugs at the time, 2 injectables, but today we have over 25 FDA-approved drugs, both oral and injectables, for MS. Visual and mobility outcomes are relatively poor with more disability. So around this time, in the 1990s, when we were training as neurologists in the Institute of Neurology at NHSL, we came across a few patients presenting to us with episodic neurology. In spite of the many challenges we had, we investigated and started to evaluate them. This is a 21-year-old girl who presented to us around that time with acute onset ataxia and bilateral visual blurring. So the MRI showed lesions in the corpus callosum, periventricular regions, as well as in the cortical, juxtacortical regions. This is a 34-year-old lady with recurring episodes of visual impairment, numbness, weakness, eventually becoming wheelchair-bound with this MRI. So with these initial cases, we wrote up the first publication on MS cases in Sri Lanka in around that time, about 25 years ago. So this time, there was no McDonald criteria, so we had to rely on the POSA criteria to make these diagnoses. And these are the initial cases that we published at the time. Subsequently, in 2011, we evaluated 35 Sri Lankan MS patients diagnosed with McDonald criteria, revised McDonald criteria of 2005. And this series of cases were presented as an oral presentation at the World Congress of Neurology, the 20th World Congress in Morocco, Marrakesh. And in these 35 cases, Caucasian ancestry was found in only one, and there was no family history. Mean age was around 29.8, and predominantly they were females. Pyramidal and sensory signs were predominantly seen with optic neuritis as well. Bladder involvement, cerebellar signs, fatigue and pain were there. Epilepsy and tremor was less common. Devick's type presentations were less common. And also they were predominantly RRMS, relapsing remitting type. 94% of them had brain lesions. Oligoclonal bands are not seen in many, so it was seen only in a minority. And they were all treated with methylprednisolone, but at the time we didn't have disease-modifying agents to treat them. Only a few were treated. So predominantly they were Western type multiple sclerosis. So this work we published in 2012 in the Sri Lanka Journal of Neurology. And it's interesting to note that only 50% were fully independent. So they had a significant disability with more than 50% having EDSS score of more than 6. And compared to that, in certain regional centers in Pakistan and so on, the disabilities were less. So EDSS stands for the Expanded Disability Status Scale, which is a method of measuring the disability in MS. 0 is normal and 10 is death, and in between you get various levels of disability. Onset age positively correlates with the EDSS, independent of the clinical attack number. Males appear to relapse less than females. However, after reaching the EDSS of 3, they have accelerated progression. So then around 2016, we started the registries. A registry of patients with all central nervous system demyelinating disorders, including optic neuritis, myelitis, and NMOSD, ADEM, and so on, at the Institute of Neurology, NHSL. This registry included the demographics, clinical features, treatment, and outcomes, and so on. And this is updated and maintained by the investigators. We also analyzed the serology in all these patients with live cell-based assays performed at Mayo Clinic, USA, for aquaporin 4 and MOG. Based on these cross-sectional studies, we did a cross-sectional study retrospectively analyzing data from the MS registry at NHSL with ethical approval. At the time, there were 191 confirmed definite cases, excluding aquaporin 4 and MOGADs. This work was published in the International Journal of Multiple Sclerosis. And at the time, we found that about 15% of all our demyelinating disorders patients were having MS. Out of the 1,270 at the time, 191 were having definite MS. And the crude prevalence we calculated at the time to be around 7.78 per 100,000 population. Demographic pattern of MS in Sri Lanka are very much like that of what we see in the West with female preponderance and average age at onset of 29 years. And the commonest clinical symptom, both at presentation as well as during the relapses, were cortical symptoms and optic neuritis. Optic neuritis was bilateral in about 10% and recurrent in about 30%. Commonest type of MS was RRMS in the majority, and all patients had brain lesions, and 63% of them had spinal lesions. The brain lesions were periventricular, juxtacortical, corpus callosal, brainstem, and the spinal lesions were mostly short segment lesions, but there were few with long segment lesions. All our patients were double negative for aquaporin 4 and MOG, so the diagnosis was precise and confirmed. Our cohort showed excellent mobility and visual outcomes, and also the disease duration. At the disease duration of 6 years, 83% were walking independently, and the median EDSS was 1. And at the further follow-up at 10 years or more, the EDSS was less than 3 in the large majority, and it was less than 2 at 5 to 10 years. So this showed a great improvement compared to the previous study. The visual outcomes were also good, with more than 60% having normal vision. And this lesser disability was obviously due to better diagnostic ability and treatment and follow-up. And also the location of the country may we postulate that it may play a role as we are closer to the equator, and the low OCB positivity. So low OCB positivity is perhaps a regional phenomenon. Within our population, people with low OCB positivity had low annualized relapse rates. However, the EDSS scores did not differ in low OCB positive patients. The low prevalence of CSF oligoclonal bands is perhaps seen in the region. So there is a paradigm shift compared to the 2012 report, where only 50% were able to independently walk. 83% of our patients now are walking independently. So there can be confounders, of course, like more patients being reported, and previous reports may have only picked the more severe cases and so on. However, certainly improved diagnostic and early treatment would have contributed to this. So what led to this paradigm shift? So we carried out awareness campaigns in 2010, from 2010 annually, to coincide with the MS Day, and this is to educate and create awareness among the medical personnel as well, to refer patients to the nearest neurology center for evaluation if these symptoms are found in any patient. And of course, there is a definite improvement in the neurological services in the country, with all 9 provinces having neurology centers, and availability of better MRI facilities. And it is found in most centers now, and higher sensitivity, 3 Tesla machines, and the availability of serology to conclusively exclude other mimics. Otherwise, there tend to be a lot of overlap. And also the availability of disease-modifying treatment through the government sector on a regular basis. And also a dedicated specialized clinic for MS was established at the National Hospital, where not only the diagnosis is made and follow-up of patients, and the registries are maintained, treatment is given, so on a regular basis. So all this would have helped and caused this paradigm shift in the outcomes. So the registries are maintained for all these conditions, and currently we have in the registry close to 300 patients with definite MS, excluding aquaporin 4 and MOG disease, and majority of them are on disease-modifying treatment, and some of them are also on rituximab, which is not a licensed drug yet, but it is widely used. So we have been continuously exploring into the pathogenesis and characteristics of our MS patients. We find that in a comparative analysis of clinical characteristics and treatment responses in men and women in our patients, which we published, that female predominance in MS seems to be less prominent in Sri Lanka and Asia compared to Europe and America. And also males presented with more spinal cord syndromes. And in our patients, progressive disease was more common in males compared to females. However, compared to females, males appear to relapse less frequently. EDSS was slightly higher in males at the last follow-up, and about 38% had EDSS more than 3.5, and 18% had EDSS of the females had that EDSS. So males relapse less, but they progress faster. So the EDSS was higher, and they were more likely to get disabilities in our series. Similar phenomena are reported internationally as well. Then we looked at Epstein-Barr virus. Now, there's a lot of interest about this. Recent study found that the Epstein-Barr virus mimics a protein made in the brain and the spinal cord, making the molecular mimicry causing immune system to mistakenly attack the body's nerve cells. So Epstein-Barr virus is called the mastermind of immune chaos. Epstein-Barr virus is a highly prevalent human herpes virus worldwide, and it is found in 90 to 95% of all adults all over the world. And sometime during their lives, they would have contracted the virus. So the body's immune system, the response to that is strongly linked to the development of MS. Severity of EBV primary infection can result in developing MS many years later. Although 90 to 95% of the global population has EBV virus, only a small fraction develops MS. So maybe the genetic and environmental factors also play a role. Late primary infection in adolescence is more associated with development of MS later on than the infantile infection. So we carried out this study to look at our patients. As I said, in the West, EBV seropositivity among adult MS patients is nearly 100%, while in the general population it's about 83 to 90%. So there's hardly any evidence from South Asia. So we did this testing on 55 patients with MS and age and gender match controls, and 96% of our MS patients had positivity for EBV VCA IgG, whereas in the general age and gender match controls, it was 85%. So there was a statistical significance there. So currently we are also calculating the titers. So the data from this region is not available to us because it has not been performed before. And so it is imperative to see whether our data and the Western data are similar. And also there is interest about vitamin D and MS. Hypovitaminosis D is a risk factor for MS. Chronic inflammatory reaction of CNS IDDs are influenced by vitamin D levels. Several studies show that people who get more sun exposure are less likely to get MS. Vitamin D may also may also benefit people with MS to reduce symptoms, and so on. So in this analysis, we looked at 60 patients, our patients with MS, and consecutively enrolled, who fulfilled cases, which is a rare phenomenon, more common in places where there is high prevalent MS. However, we had siblings as well as a mother and a son pair. So there is a 7-fold increase for MS, first degree relatives to get MS. And it is more common among siblings, sister-sister pairs, lowest between father-son and mother-son pairs. This is not reported from South Asia. So we reported these cases. And this is our mother and son. Both had pretty much the same kind of clinical presentation. However, the mother was having more progressive disease with a higher EDSS score. And this is the MRI of the mother showing more atrophy compared to the son on the right-hand side. But pretty much the same with spinal lesions, brain lesions also. And the OCT also showed involvement of optic nerves bilaterally severely affected in the mother, and son, it was asymmetric but bilaterally affected. Then we looked at the cognitive difficulties and depression in MS. And this work was also published, a cross-sectional descriptive study where we looked at cognitive impairment in MS patients, which is known to occur in about 40 to 65% of patients with MS. We studied about 100 MS cases, randomly selected using a direct interview and patient registry. They were all seronegative for aquaporin 4 and MOG. MMSC, MoCA, and Beck's depression score was used to evaluate them. We found that they had cognitive impairment in 63% of the patients had cognitive impairment, and about 50% had depression. 50% of cognitively impaired patients were also depressed, but association was not statistically significant. So the cognitive impairment was associated with the time to first relapse, and depression was associated with the duration of the diagnosis. Then we looked at the TPO antibodies. TPO antibodies and CNS demyelination. Thyroid hormones play an important role in myelin turnover and CNS myelination. So anti-thyroid antibodies are known to cause demyelination. TPO antibodies related to higher occurrence of transverse myelitis, higher lesion load, MRI, and worse disability outcomes. So here we evaluated and looked at, we tested the TPO antibody levels in 140 patients. In the healthy population in Sri Lanka, children, about 10%, will have TPO antibodies, and adults, again, approximately 10%. And in our study, we found that in aquaporin 4, there was significantly higher number of patients with TPO antibodies as opposed to the general population and also MS. So it was significant in aquaporin 4. Patients with aquaporin 4 and MOSD had overall higher titer. Neither the visual nor the motor outcomes were significantly associated with TPO antibody positivity. The absolute TPO titer did not correlate with the disability scores. Currently, we are looking at the neurofilament light levels in these patients, which is now known as the Neurologist troponin. So neurofilament light is a cytoskeletal protein, highly specific for neurons, promising biomarker, can be measured in biofluids. And the ELISA techniques checks it in the CSF, but now with ultrasensitive assays quantified in blood as well, we can check it. So it is a potential biomarker for disease activity and treatment responses. Clinical threshold and reference measurements need to be developed. So we are looking at this right now. Samples are being collected and we are testing at the Medical Research Institute. It's an observational cohort study for the levels of neurofilament light in patients with MS. So there is a prognostic value of doing the NFL levels. Higher levels correlate with development of more GAD positive lesions, increase levels in relapses, increased risk of future relapses, correlates with long-term outcomes, and so on. Then the bladder dysfunction in MS we looked at, and we published some work on this as well, with over 90% of the patients with MS experiencing some degree of voiding dysfunction with or without incontinence. And we carried out and administered this actionable questionnaire on them and tested them with ultrasound scanning, pre and post void, after treatment with tolterodine and tamsulicin. Same questionnaire was done 10 weeks later, administered, and also the plaque location was looked at. And there we found that mean duration of the disease was about 10 years, and the average EDSS was around 4, and the commonest type of bladder involvement was hypertonic, non-compliant bladder with outlet obstruction. Majority of the patients had bladders with no risk to upper tracts. The mean actionable symptom screening score pre and post treatment was 5.1 to 2. 91% had demyelinating plaques in the cervical and dorsal spine, people with bladder involvement. Symptomatic treatment can significantly improve the quality of life in these patients. Also, we looked at the OCTs, which is now non-invasive method of imaging method to test the functions of the optic nerve, cross-sectional pictures of the retina, mapping of and measuring their thickness to evaluate disorders of the optic nerve. So this work was carried out in 38 patients, and we found at 3 months testing there's significant RNFL thickness lowering in both MS and MOGADs. And also mitoxantrone, which is a drug which is widely used in hematological malignancies, is now used for aggressive MS. It's a cheap option for us. So we did use this in 8 of our bad patients with MS, and we had some good results in about 50% of them, with the EDSS dropping significantly. However, there are a lot of side effects with this kind of medication, but it's effective in very advanced cases. In the absence of more refined products like alemtuzumab and cladribine, this is a cheap option to use in bad patients. So, 25 years later, MS is now taught in all medical schools as a subject. So there is greater awareness. We have better MRI scanners, and it's widely available. And of course, the medical personnel, health policymakers know more about MS. There are treatment options. And also, we zero test for aquaporin 4 and MOG in all our patients. So the diagnosis is more precise, more accurate. And of course, the insurance companies are now listing this as a critical illness. However, not everything is MS. So Eugene Devic is a French neurologist. In 1894, he described this single case of a patient, a 45-year-old woman who had transverse myelitis with optic neuritis bilaterally. And the patient subsequently developed the transverse myelitis and died, and he did the autopsy and found that the pathology at the optic nerves and the spinal cord were pretty much the same. So he came up with this neuromyelitis optica diagnosis, and his PhD student Galt Soon after, a further 16 cases were evaluated, and they thought that this was a variant of MS. However, this disease has undergone a tremendous amount of evolution over the last 110 years, from David to Wanda Lennon, who's the founder of the Mayo Clinic Neuroimmunology Lab. And this is a groundbreaking discovery in 2004, where the serum autoantibody, specific autoantibody marker, NMO-SD marker was found. It was termed aquaporin 4 antibody, discovered at Mayo Clinic. So this enabled us to decisively exclude neuromyelitis optica and separate it out from MS. It's a unique disease entity. So this is a very specific biomarker. So with this discovery, the so-called opticospinal MS, which was described in Asian countries, has gone out of the way. So it's no longer there. So in 2005, 1 year later, the antigen was discovered, and after that, of course, the NMOSD, the term, came into being again from Mayo Clinic. So the second antibody, MOG antibody, was then discovered a few years later in patients who were negative for aquaporin 4 with presentations similar to neuromyelitis optica. So these three conditions, neuromyelitis optica spectrum disorder, MS, MOGAD, aquaporin 4 has similarities. That is the problem. So now we are in a position to separate them out. Although they have similarities, certain differences. And the brain lesions again are in different places. So you might be able to separate them out on the radiology as well. However, with the serology, we are able to properly rule that out. So we started this collaboration with Mayo Clinic in 2013, 10 years ago, more than 10 years ago, and to test our patients, all our patients with the aquaporin 4 and MOG antibodies. So all our patients with demyelinating disorders have been tested over that period. More than 2,400 patients have been tested, entirely funded by Mayo Clinic. We have been having the collaborator meetings annually in the US with only a short break for COVID. And this work has been going on for a very long time. So with this, we have been able to come up with a more precise diagnosis for our MS patients. Right. So currently, as I said, we have about 300 patients who are definitely having MS and about 250 with MOG positivity and close to 100 with aquaporin 4 with serotesting done properly with a live cell-based assay at Mayo Clinic. So this work has been published as well in the JNNP BMJ presentation, BMJ journal. And we find that about 1/6 of our patients with MOG have MOG antibody positivity. It is more common in children. And our paper has been cited in many other publications as well, and most importantly, by the International MOGAD panel, which proposed the criteria last year and came up with the criteria. So our paper is also cited there. And also we published the work on aquaporin 4 in the International Multiple Sclerosis Journal. Right, so I will just run through this. So comparison of MS, NMOSD and MOGADs in Sri Lanka, we find that MS and MOGADs were younger compared to aquaporin 4 patients, and striking gender differences there in aquaporin 4. And optic neuritis is the commonest presentation in MOGADs, and transverse myelitis in aquaporin 4 and NMOSD. Relapses are more commonest in MS. While MS patients had excellent visual outcomes, NMOSD patients had less favorable outcomes. Right, so finally moving forward, to facilitate and create synergies and promote research and learning for the benefit of patients affected by this condition, we came up with the idea of having a professional body for this on the same lines as the international or regional bodies like that. So Sri Lanka Committee for the Treatment and Research in MS and related disorders was a result of that. In 2018, we formed this organization, and we have had 5 international annual congresses since then, with very prominent international faculty being here. This is a short video on that before we just wind up.
The Sri Lanka Committee for Treatment and Research in Multiple Sclerosis is the national counterpart of global organizations such as PACTRIMS and ECTRIMS, focused on advancing the understanding and treatment of multiple sclerosis and related neurological disorders. On recognition of the need to further develop Sri Lanka's commitment towards academic, clinical and curative aspects of this group of neurological disorders, the idea of establishing SLICTRIMS was conceived in the minds of 5 pioneering Sri Lankan neurologists: Dr. Bimsara Senanayake, Dr. T. Thivakaran, Professor Sershi Chang, Dr. Harsh Gunasekara, and Dr. Arjuna Fernando. The combined effort, dedication, and planning of these neurologists led to the launch of SLICTRIMS in 2019. Since its inception, under the leadership of the founding president Dr. Bimsara Senanayake, SLICTRIMS has organized 5 consecutive fully fledged international annual academic congresses in Sri Lanka, bringing in the most acclaimed and globally recognized neurologists in the field of MS and related disorders to the island. Notable personalities include Professor Giancarlo Comi, President of the European Chakra Foundation, and Professor Kazuo Fujihara, President of PACTRIMS. SLICTRIMS has significantly advanced education and research on MS and similar conditions in Sri Lanka by offering research grants, fostering international collaborations, and opening up opportunities. Notably, the 2024 ECF Young Investigator Award for Innovation and Research in MS was won by a Sri Lankan. These meticulous efforts have paved the groundwork leading to systematic institutional collaborations between SLICTRIMS and the highly coveted European Chakra Foundation and Mayo Clinic USA.
Right, to wind up on a happy note, this is also a story of a young accountant. She's
මට වයස 28යි මම accountant කෙනෙක්. මට මේ ලෙඩේ මුලින්ම හැදුණු 2021 කොවිඩ් වැක්සින් එක විද්දට පස්සේ මගේ අත් දෙක හිරි වැටුණා. ඒක අඩු වෙලා කකුල් දෙක හිරි වැටුණා. ඊට පස්සේ කෙවල් ළඟ ડોක්ටර්ට පෙන්නවම MRI පරීක්ෂණයක් කරන්න කිව්වා. ඒකෙන් මට ට්‍රාන්ස්ෆර් මයිලයිටිස් රෝගය තියෙන්නේ කියලා පෙට්‍රිසිරෝන් බොන්න කියලා නියම කරා. ඊට පස්සේ හොඳ වුණා. 2022 ජූනි මාසේ මගේ වම් ඇහැ චලනය වෙන එක නතර වුණා. ඊට පස්සේ කොළඹ ජාතික රෝහලේ ස්නායු වෛද්‍යකගෙට පෙන්නුවාම මට මල්ටිපල් සිරෝසිස් රෝගය තියෙන කියලා කිව්වා. ඊට පස්සේ රෝහල්ගත වෙලා දවස් 5ක බෙහෙත් කෝස් එකෙන් පස්සේ මට හොඳ වුණා. ඊට පස්සේ දීර්ඝකාලීනව බොන්න කියලා ෆින්ගොලිමඩ් මට නියම කරා. ඊට පස්සේ මට කිසිම රෝග ලක්ෂණයක් පෙන්නුවේ නැහැ. ඊට පස්සේ මට හොඳ වුණා. මම දැන් මාස 4ක ගැබිණි මාතාවක්.
right. Thank you very much, and these are my references. And I would like to thank the research team, especially Dr. Maithili Aravindan, who's co-author in most of my work, and also the others, and also the untiring team, Amila Kure and Himal Jayadilaka especially, and my parents and my family who are here, Nilanti, Shamindri, Sayuri and Charini. Right. And of course, my mentor, teacher, guru, Dr. Jagat Vijayasekara. Thank you so much.